So you're sitting on your couch on a Friday night.
Right, yeah. Just relaxing.
Yeah, you're watching this really tense horror movie. The protagonist is, slowly walking down a dark hallway. The music swells, and you haven't even moved a muscle in like an hour.
Just completely frozen in suspense.
Exactly. And then suddenly your wrist vibrates. You look down and your smartwatch screen is just flashing red. It says high heart rate detected 115 BPM.
And suddenly the movie isn't the scariest thing in the room anymore.
Right. You aren't thinking about the movie at all. You're sitting there wondering, like, am I about to have a heart attack? Or is my expensive gadget just acting up?
It's a really terrifying moment for a lot of people.
It really is.
Yeah.
Because we trust numbers on screens implicitly, Just like the speedometer in a car. If it says 90 miles an hour, well, you're going exactly 90 miles an hour.
Yeah, but when those rigid numbers collide with the incredibly dynamic environment of the human body, well, that expectation of absolute precision just completely breaks down.
Okay, let's unpack this. Welcome to today's deep dive. Our mission today is to demystify two of the most common, yet honestly most misunderstood prefixes in medical terminology.
Right, we're talking about Brady and Tachy.
Exactly. Brady meaning slow and Tachy meaning fast. So whether you're prepping for a medical exam or you're just someone who's been totally spooked by a digital alert on your wrist, we're going to see why the numbers on the screen are really only half the story.
And setting this vocabulary straight right from the jump is so crucial. The language of medicine is it's most valuable when we actually understand the biological mechanisms behind the words,
Yeah, because the labels dictate the treatment.
Exactly. They dictate how we diagnose, how we interpret risk, and ultimately how we treat a patient.
I think the easiest way to visualize this is to think of medical terminology like a set of Lego bricks.
I love that analogy.
Right. So Brady comes from the Greek word Brady's, meaning slow.
Right.
Tachy comes from Tachy's, meaning fast. But you can't just hand a doctor a chart that says Tachy.
No, you definitely can't.
Because they're just rate modifiers. You have to click that prefix onto a root word that tells you what actual physical structure in the body is moving fast or slow.
Right. They are naked modifiers. By themselves, they mean nothing. If you attach Brady or Tachy to the Greek root cardia for heart, you build the words Bradycardia, a slow heart rate, and Tachycardia, a fast heart rate.
Which are terms people throw around all the time.
They do.
Yeah.
And conventionally, for an adult at rest, the medical establishment defines bradycardia as anything under 60 beats per minute.
Okay, under 60.
Yeah, and tachycardia is anything over 100 beats per minute. But the absolute most important takeaway here is that these prefixes are purely 100% about speed.
They describe rate. Full stop.
Full stop.
They don't tell you if the rhythm is regular or irregular. They don't tell you why it's happening. And they definitely don't tell you if you're actually in danger. But people hear tachycardia and immediately assume it's this horrible disease. I hear it all the time. People will say, like, my doctor says I have tachycardia, as if it's the exact same thing as saying I have diabetes.
Right, which is a huge misconception. A fast heartbeat isn't inherently a diagnosis.
It's not.
No, it's often just a totally appropriate physiological reaction. Like, if you're sprinting down the street to catch a bus, your heart is going to beat fast.
Oh, for sure.
It might hit 140 beats per minute. That is a completely normal response to an increased demand for oxygen in your muscles. We call that sinus tachycardia.
And just to clarify the jargon there, because when you say sinus, I feel like people immediately think of, the sinuses in their nose.
A very fair point, yeah. In cardiology, sinus refers to the sinoatrial node.
Okay.
Which is this tiny cluster of specialized cells in the upper right chamber of your heart. It basically acts as the heart's natural built-in pacemaker.
Oh, wow.
So sinus tachycardia just means your natural pacemaker is firing normally, but it's firing fast because you were running for a bus. The electrical origin is perfectly healthy.
So the gears are turning exactly as they should, just at a higher RPM.
Exactly. Pathological tachycardia, the kind that actually worries cardiologists, implies a resting rate that is inappropriately sustained.
So it's fast when you're just sitting on the couch.
Right, when there's absolutely no physiological demand for it to be fast.
Okay, let's explore that 60 and 100 beats per minute boundary. Because if human bodies aren't machines, how did we even settle on these rigid speed limits?
It's a great question.
Because the terminology actually predates the technology to measure it by centuries, right? Like we're talking about ancient Greek medicine, the Hippocratic corpus, and Galen back in the 2nd century.
Yes, and what's fascinating here is how Galen mapped out the pulse. He called it the sphygmos, and he did it entirely by feel.
Just with his hands.
Just his fingers. He didn't have a stopwatch, a stethoscope, or an Apple Watch.
Right.
He categorized speed purely as a descriptive sensation, alongside the strength and the volume of the pulse.
That's wild.
He would literally press his fingers to a patient's wrist and feel that a pulse was languid or quick. And he built entire diagnostic categories based on those subjective sensations.
He was essentially reading the fluid dynamics of the blood with his fingertips.
Exactly.
So how do we get from a Roman physician feeling a languid pulse to a strict rule that, 59 beats per minute is bradycardia and 60 is totally normal?
Well, we get there through the industrial revolution of medical technology in the 19th century.
Okay, so the machines arrive.
Right. During the 1860s and moving into the early 1900s, there's this massive shift. Clinicians in France began heavily utilizing the word tachycardia, and bradycardia became widely adopted shortly after.
Interesting.
But this linguistic shift happened right alongside the invention of devices like Etienne Jules Méret's fibrograph in 1860.
Oh, I've seen pictures of that. That was the device that literally strapped to the wrist and used a tiny lever to scratch the pulse wave onto a rotating cylinder of soot-covered paper, right?
That's the one. It looks like a little steampunk gadget. And it was followed by Willem Einthoven's invention of the string galvanometer in 1901.
Which was a big deal.
A huge deal. It gave us the first true electrocardiograph, or ECG. Suddenly, you weren't just feeling a pulse. You had an objective, continuous line drawn on paper, scrolling at a very specific speed.
Which changes absolutely everything about the vocabulary, because once you draw a grid on a piece of paper, you're basically forcing the doctor to count the peaks.
Exact.
You have to anchor those ancient, vague feelings of slow and fast to hard mathematical cutoffs, just to standardize how you even talk about the graph.
Precisely. Technology forced a change in the language. But as you can imagine, locking an ancient descriptive word to a rigid number on a machine creates an entirely new problem.
Right, because you lose the human element.
You risk treating the graph instead of the patient sitting right in front of you.
And that tension between the mathematical number and the actual human being, that seems to be the core challenge in modern medicine right now.
It really is the biggest debate in cardiology today.
Because, 28 beats per minute is objectively, mathematically severe bradycardia. But if we look at someone like the legendary Tour de France cyclist Miguel Indurain...
Oh, his case is legendary.
Yeah, his resting heart rate at his peak was reportedly 28 beats per minute. And he obviously wasn't dying, he was winning world championships.
Indurain is the textbook example of the athlete's heart. Through years of extreme cardiovascular endurance training, his heart underwent profound physiological remodeling.
Because the heart is a muscle, right?
Exactly. And his became incredibly efficient. It developed a massive stroke volume.
Meaning the sheer amount of blood ejected with every single squeeze is just huge.
Right. Because his left ventricle could hold and pump so much oxygen-rich blood in one massive contraction, his body simply didn't need the heart to beat very often to maintain normal blood pressure while he was resting. So his 28 beats per minute was a highly efficient, benign sinus bradycardia.
But if a sedentary 70-year-old walks into a clinic with a heart rate of 28...
the clinical picture flips entirely. That patient is likely experiencing a profound failure of their heart's electrical system.
Like a block or something.
Yeah, like a complete heart block. They're probably dizzy, feeling faint, and heading straight for an emergency pacemaker implantation.
But the number is the exact same.
The number on the monitor is identical to Indurain's. But the mechanical reality inside the chest is completely, totally different.
It's the exact same dynamic on the other end of the spectrum, too, especially in emergency medicine. A high number on a monitor in a triage bay is one of the most reliable red flags a nurse has, right?
Oh, absolutely. A resting heart rate persistently over 100 beats per minute is an incredibly sensitive alarm bell.
Even if it's not super specific.
Right. It's unspecific, but very sensitive. If a patient comes into the ER with tachycardia paired with low blood pressure, that combination immediately raises the suspicion for massive systemic danger.
Like what kinds of things?
Things like severe internal hemorrhage, profound dehydration, or sepsis.
Which makes perfect mechanical sense if you think about it like plumbing.
Yeah, plumbing is a great way to look at it.
Like if you have a pipe that's leaking fluid or blood vessels that are massively dilated from a systemic infection like sepsis, the pressure in the system just plummets.
Right.
So the body senses that low blood pressure and the brain tells the heart to pump twice as fast to try and compensate, just to keep blood flowing to the vital organs.
Exactly.
So the fast heart rate isn't the primary problem at all. It's the body's desperate attempt to solve a pressure problem.
That's spot on. But if that rate pushes even higher, say cresting over 150 beats per minute, the terminology and the treatment algorithms shift all over again.
Okay, how so?
At that speed, if the rhythm on the ECG looks narrow and sharp, clinicians will often classify it as supraventricular tachycardia, or SVT.
Let me stop you there for a second, because narrow complex rhythm is a term that gets thrown around in medical dramas all the time.
Oh, definitely.
What does that actually mean when you're looking at an ECG?
So when you look at an ECG trace, a narrow complex means the literal spike on the paper, the QRS complex, is very skinny.
Okay, skinny spike.
Physiologically, that tells the doctor that the electrical signal is traveling down the heart's normal, built-in superhighways. It's moving fast and efficiently through the proper channels in the ventricles.
And if it's wide?
If the spike is wide, it means the electricity is taking a slow, dangerous detour through the surrounding muscle tissue, which is a much bigger emergency.
Okay, so that distinction leads us right into what cardiologists call the arrhythmia trap.
Yes, this is so important.
It's the danger of seeing a fast number on the monitor, calling it tachycardia, and thinking you've made a diagnosis.
Which happens way too often.
Take a patient in atrial fibrillation. Their monitor might read 160 beats per minute. But basically, calling atrial fibrillation just tachycardia is like saying a house fire is just an abnormally warm living room.
I really like that analogy.
Right. It's technically true, but you're missing the point.
Entirely missing the point. And to push the house fire analogy a bit further, calling it an abnormally warm living room completely ignores the fact that the electrical wiring inside the walls is actively melting.
Exactly.
The sheer speed of 160 beats per minute in atrial fibrillation is bad, but it isn't the primary danger.
The danger is the mechanics of the rhythm itself.
Precisely. In atrial fibrillation, the upper chambers of the heart, the atria, aren't giving a coordinated, firm squeeze. They are just quivering chaotically.
Like a bag of worms.
Exactly like that.
Yeah.
And because they're just twitching, they don't empty completely. Blood starts to pool and stagnate in the little crevices of the heart. And what does blood do when it stops moving?
Like clots.
It forms clots. If one of those clots breaks loose and shoots out of the heart and into the brain, it causes a massive stroke.
Wow, so labeling the patient merely with tachycardia totally masks the true pathological threat.
It does. The numbers are just guidelines. Understanding the structural reality and the patient's symptoms are what actually dictate whether you give them medication to slow the heart down or blood thinners to prevent a stroke.
So what does this all mean? We spent a lot of time in the chest cavity talking about the heart. But let's take those Lego bricks we talked about earlier and move them to a completely different system.
Let's do it.
Because the prefixes, Brady and Tachy, can travel anywhere in the body where there is a rate to measure.
Any rate at all.
So let's look at the lungs. We have the Greek root apnea for breathing. Eupnea is a normal, unlabored breathing rate. Apnea, using the 8 prefix, means a complete absence of breathing.
Like sleep apnea.
Exactly. And then we have bradypnea, abnormally slow breathing, and tachypnea.
Right. Tachypnea, which is generally defined in a resting adult as breathing more than 20 times per minute. And I have to say, this is a metric that is notoriously underrated in clinical medicine.
Which is wild to me because from a purely physiological standpoint, tachypnea is consistently one of the earliest signs that a patient is crashing.
It's a huge red flag.
It shows up before the oxygen monitors even start beeping in conditions like pneumonia, sepsis, or a pulmonary embolism, which is a blood clot in the lung. Why does the breathing rate spike way before the oxygen actually drops?
It really comes down to how the brain monitors the blood.
Yeah.
The respiratory center in your brainstem isn't primarily driven by a lack of oxygen. It's actually hypersensitive to the buildup of carbon dioxide and acidity in the blood.
Oh, really?
Yeah. So if you have a severe infection, your tissues are working in overdrive and dumping acidic byproducts and CO2 into your bloodstream. Your brain detects that rising acid level instantly, long before your oxygen reserves are depleted.
That makes so much sense.
Right. So it immediately triggers the lungs to breathe faster to tachypnea, to literally blow off the excess carbon dioxide and balance the blood's pH.
It's basically an early warning siren.
Exactly. But despite being so crucial, it is incredibly common for tachypnea to be documented incorrectly in hospitals.
Why is that?
Well, clinicians are often hurried, so they might count a patient's breaths for 15 seconds and just multiply by 4.
Oh, sure. Just to save time.
Or they run into the observer effect.
Wait, what's that in this context?
If you walk into a room and tell a patient, I'm going to count your breaths now, their subconscious takes over. They instantly alter their breathing pattern, usually slowing it down.
Oh, I totally do that. I'd start thinking about my breathing immediately.
Everyone does. This is why rigorous clinical training explicitly dictates that you must count the respiratory rate for a full minute, ideally while pretending to check their pulse so they don't realize you're watching their chest rise and fall.
That's sneaky, but brilliant. I also want to clear up a massive misconception here because people use the terms tachypnea and hyperventilation interchangeably all the time.
They really do.
If someone is breathing fast, people say they're hyperventilating, but physiologically, those are two very different concepts, right?
They are completely distinct. Tachypnea is purely a description of the rate of breaths. Hyperventilation is a description of the adequacy of gas exchange, specifically clearing out too much carbon dioxide.
Okay, break that down for me.
So you can be tachypneic, breathing a frantic 30 times a minute, but if those breaths are incredibly shallow, barely moving air past your windpipe, you aren't exchanging gas in the deep tissues of the lungs.
Ah, so you're breathing fast, but it's not actually doing anything.
Right. In that scenario, despite the fast rate, you are actually hypoventilating.
Which is why relying purely on the prefix for speed can lead you down completely the wrong diagnostic path.
Exactly.
Okay, so we've covered the heart and the lungs, but the reach of these prefixes extends into neurology, too.
Yes, the nervous system.
Let's look at the root parkinesia, which refers to movement. If you attach brady to it, you get bradykinesia.
Abnormally slow movement.
Right. And bradykinesia isn't just moving sluggishly because you're tired. It is a cardinal defining symptom for diagnosing Parkinson's disease. And the mechanism behind it is fascinating. It's a profound neurological delay. The brain wants to move the arm, the signal is generated, but because of a progressive loss of dopamine-producing cells deep in the brain's basal ganglia, the signal just degrades.
Yeah, the basal ganglia is essentially the brain's motor control switchboard.
Mm-hmm.
Without enough dopamine, the switchboard just can't initiate the movement smoothly.
It's like trying to drive a car where the clutch is slipping.
That's exactly what it feels like.
The engine is revving like the brain is sending the command, but the transmission can't engage the wheels. Patients experience this hesitation before they can start walking, or they see a progressive shrinking of their movements, like their handwriting getting smaller and smaller.
It's a structural neurological deficit, yet it shares the exact same linguistic root as a slow heartbeat.
That's just wild to me.
It really highlights the underlying elegance of medical terminology. That one simple Greek prefix connects a cardiology workup, a respiratory distress alert in the ICU, and a neurological diagnosis of a degenerative brain disease.
Here's where it gets really interesting, though, because this brings us back full circle to where we started. The smartwatch.
Ah, yes.
This distinction between a strict numerical rate and the surrounding human context, it isn't just a philosophical debate for medical students on clinical rotations anymore.
Not at all.
Because of the massive explosion of consumer wearables, the Apple Watch, Fitbit, the Oura Ring, this ancient Greek vocabulary is currently sitting on the wrists of millions of people.
If we connect this to the bigger picture, those devices are relentlessly measuring, processing, and alerting all day long.
They're constantly sending notifications that say tachycardia detected or irregular rhythm, and it's triggered this massive wave of what doctors are calling digital hypochondria.
Yes, it's a huge issue in clinics right now.
Consumers are receiving these rigid numeric alerts and immediately self-diagnosing. But the real problem is, how is the watch actually getting that number? Because it's not an ECG hooked up to your chest.
No, most of the time it's using something called photoplethysmography.
Right, those little flashing green LEDs on the back of the watch.
Exactly. They shine light into the skin of your wrist and measure how much light scatters back. Every time your heart beats, a wave of blood swells the tiny capillaries in your wrist, which absorbs more green light.
Oh.
Okay. So the watch is literally just counting the micro-expansions of the blood vessels in your skin.
Which is an incredible piece of engineering, but it is a surrogate measurement.
Right. It's not measuring the electrical spark of the heart. And because it's measuring capillary expansion on a moving limb, it is highly susceptible to artifacts.
Like what kind of artifacts?
Well, if the watch is loose, if you're gripping a steering wheel tightly, or even if you're just typing vigorously on a keyboard, the sensors can totally misinterpret that mechanical movement as a pulse wave.
Oh, wow. So the watch misreads the data, flashes 120 beats per minute alert, and strips away all the clinical context.
Absolutely.
It doesn't know you just drank 3 double espressos. It doesn't know you're fighting off a mild fever, which naturally raises your heart rate. And it certainly doesn't know if you're just sitting on the couch intensely watching a horror movie.
Exactly.
It basically acts like an anxious backseat driver who only stares at the speedometer and screams when you hit 70, completely ignoring the fact that you are safely merging onto an empty highway.
And that anxiety is precisely why many cardiologists are pushing back against the default settings of these unvalidated alerts.
Because it's flooding the system.
Yes, they generate enormous volumes of unnecessary medical appointments for perfectly healthy people. The technology is amazing, don't get me wrong, but we are allowing a consumer algorithm to bypass the entire diagnostic process.
So for the listener who wears one of these devices, what is the golden rule when your wrist just starts buzzing?
The rule of thumb is that an alert from a wearable is a prompt, not a medical verdict.
Okay, a prompt.
Right. It is simply a prompt to check in with your physical reality. If your watch says your heart rate is high, do a systems check. Are you dizzy? Do you feel shortness of breath? Are you experiencing chest pain or extreme fatigue?
Check for actual symptoms.
Exactly. If you have a digital alert paired with actual physical symptoms, absolutely, contact a clinician. But an isolated alert, completely stripped of context and symptoms, is not an automatic diagnosis of disease.
It all comes back to the Lego bricks, really.
It does.
Brady and Tachy are just modifiers for speed, fast and slow. A number below 60 or above 100 is just a starting point plotted on a graph. The real diagnosis and the true understanding of human health relies entirely on the mechanical reality, the symptoms, and the clinical judgment that surrounds that number.
Which leaves us with a rather profound question to consider as we look to the future.
Oh, I like profound questions.
The definitions of fast and slow that we've discussed today, that rigid boundary of 60 and 100 beats per minute, are merely population conventions based on the physiology of how humans live right now.
And as we learned from Galen and the invention of the ECG, those definitions can and do shift.
Exactly. So what happens as our species continues to evolve? Or perhaps more imminently, what happens as we continue to merge with artificial pacing technologies and biohacking?
Oh, wow.
If sedentary lifestyles become even more extreme, or conversely, if genetic interventions drastically alter our cardiovascular efficiency, will those numbers hold? It is entirely possible that the medical dictionaries of the next century will have to completely redraw these lines.
That's crazy to think about.
What we rigidly defined as tachycardia today might just become tomorrow's perfectly normal, unalarming baseline.
That is a wild thought to end on. The machine might redefine the vocabulary all over again. Well, next time you look down at a notification on your wrist, remember, you aren't just looking at a raw number. You're looking at a centuries-old conversation between ancient Greek medicine, modern sensor technology, and the totally unique context of your own body. Thank you for joining us for this deep dive into the language of medicine. Stay insanely curious, and we will catch you next time.